Good evening. So today I'll be talking about the MBBS training during the pandemic. So in 2020, as we were struggling to deal with the COVID-19 crisis, we also realized that the much familiar trajectory of medical education was also significantly disrupted by the pandemic. And we had to quickly come up with novel strategies and adapt to make sure that the learning continued in the most effective manner. So, over the next few minutes, I'll be talking about how our Department of Medicine improvised the UG curriculum for the final years who were posted with us, ideally for about 4 months duration, which was shrunk to 1 month because of the pandemic. I'll also be talking about what were the challenges we faced with the new system of education, what were the lessons that we learned, and also what was the students' feedback. So the most important part was transitioning to an online platform. Then we had to make an action plan. So as I said before, the same set of skills that we were so used to transferring to the students, we had to do that in a completely new and innovative manner. So that required quite a bit of planning. We also had to identify challenges on the go because this was something which was completely new to us also. And finally, we had to make dynamic adaptation to novel strategies. So if you look at UG teaching, it mainly comprises of four main aspects: the lectures, the clinics, the assessment at the end of the posting, and also a feedback from the students, which was very important to keep the teaching go on in a most effective manner. So I'll be briefly talking about each of these four aspects and how our department actually dealt with these four aspects in a little bit detail. So coming to lectures, we know that there are many online platforms on which lectures can be taken. What we found familiar and useful was Teams. So all our online lectures and even the faculty and the unit discussions were on Teams. So the good thing about Teams is that we could have different batches with their different personalized access into each of them. And within Teams also, it could be the batch could be further divided into multiple clinical groups, and we could access only those groups as required. Lectures could be scheduled by the curriculum department, and the students could actually post their queries and comments on that. After the lecture, the lectures could be stored as PowerPoints and also recorded videos in Teams, which the students could look to later on. So the most challenging part about online lectures was trying to keep it interactive. As we know, when we have in-person classes, it's the audience interaction which gives us feedback on the knowledge gap, and that helps us to guide the content and how to move forward with the teaching. But in the online platform, the main problem is that there is not much interaction. Most of the students' videos are switched off due to connectivity problems. So it just feels like we're talking to a blank screen. So interaction was a major problem. So how we try to keep it interactive and make sure there was some active effort from the students going on. Uh, we could embed quizzes like this in between the lectures. This is not from the students, but a similar lecture, I mean, quizzes from Google Forms or Teams Forms could be inserted between the lectures. Other ways were these are other apps such as Kahoot and Poly and Poll EV, etc., which are available online, which gives very creative ways to keep the students occupied. So they had polls, surveys, all those things, which would help in interaction with the students. So what do the students feel about this at the end of the lectures and the postings? 2 week, so all these students are currently interns, so we had actually taken a feedback from them. Two-way communication and clarifying doubts was more difficult with online platform. Our attention span was much lesser with online teaching compared to classroom teaching. Some lectures had quizzes and polls in between, which helped us to stay in focus. So I think the take-home point in this would be to keep the lectures as interactive as possible, and our faculty are encouraged to add more quizzes, polls, and such things between their lectures. Coming to clinics. Again, the four core elements of clinics would be history, examination, approach and synthesis of the signs and symptoms to come to a diagnosis, and the background clinical knowledge of the practical cases. So I'll be coming to each of it. So our 5 units had different ways of actually going about each of these aspects. So I've put together all the different ways in which our units went about with taking class on each of these aspects. So history, actually, there are 3 different methods in which we try to teach them history taking. The commonest one was giving them printed cases. So we gave them unstructured history in layman words like how a patient would say. That was printed and given to the students. The students had to construct a complete history from that paper and present it to the faculty. Anything that was missing, like any note on extra history that was required, was noted. And this was subsequently discussed with the faculty. And the focus of the discussion was mainly approach to symptoms and synthesis of clinical diagnosis. Another method which we did was using a surrogate patient. So this was usually a postgraduate. We gave them the printed case with details on the history, and the students had to call up these postgraduates and take a history from them. And this history was subsequently presented to the faculty. So this gave them the art of history taking was further more refined in this method compared to the previous method. And finally, the third method was an actual patient was identified in the ward. We obtained consent from the patient and the student spoke to the patient or the relative over the phone. So this was closest to a real life scenario. So again, what was the students' feedback on the different modes of history taking? We found talking to surrogate patients the best possible way. Taking history from real patients on the phone was okay, but there was some communication gap and they were reluctant to give complete history. Maybe priming them well before us calling will help. Paper cases helped us in a complete understanding of the case. However, it's far from how things are in a real scenario. So it looks like surrogate patient history taking would be one of the better methods of teaching them history on an online platform. Real patients is the best way, however, that requires significant priming of the patients and informing them before actually going ahead with that method. Next, coming to examination. So examination is something which seamlessly flows when we're taking bedside clinics. But however, we realize that when we're taking online clinics examination aspect, there are multiple core elements that we had to give separate emphasis to. Each of this, that is a technique of examination, positive clinical findings picking up, and synthesis of signs and symptoms required separate focus. So first I'll be talking about how we taught them the technique of examination. So one of the most useful things that we found were online material. There were a lot of online channels, especially YouTube videos, that give very good detailed examination videos. So from our personal experience, Geeky Medics and Stanford Medicine were 2 online YouTube channels which gave really good explanation of the examination techniques. And these links were shared with the students and they watched it multiple times. So this was something which was really useful. There was another novel method which was done in our unit, that was examining a family member. So in this, the students, so they were all at home for the lockdown. So they were given a particular section of examination. They had to examine a family member in the video. And that video was shot by somebody else. And that video was played during the clinics. And the faculty would correct the methods and point out the errors. I'll just show a small video of how they were given motor system examination. And they actually came up with a very impressive video of the examination. So I'll just play it for a short period. I'll just fast forward it. So this was a video that they had taken, just a short clip of that. So it was actually very impressive how thoroughly they had learned the technique of examination through this method. And the fact that it was played to the faculty during clinics also helped us to assess it and see if there were any glaring errors that we had to correct. So next is identifying the positive clinical signs. So this actually was the most challenging of all the aspects of teaching clinics through an online platform. But we did try to keep it as close to real life teaching as possible. So again, there are multiple ways in which we try to teach them the positive clinical signs. Um, One was having an in-house repository of pictures and videos. So what we did was we encouraged our junior faculty and PGs who were rounding in the ward, whenever they saw an interesting finding or interesting clinical finding in the ward, they had to take a video or a picture and upload it in a Teams folder. And this folder had access only for the faculty, and based on the clinics or whatever they were teaching, they could take the particular clinical finding from the folder and show it to the students. So actually this is still in our infancy, and this requires a lot more work from our department also. Next is online material. So as you know, there are plenty of online material available, and how we kept it more interactive was based on the case, the students were asked to find online pictures and video clips of pathological findings. For example, if the case discussion was on CLD, the students were told find all pictures of all peripheral signs of CLD. So this enabled an active learning, and also they became thorough with what are the positive clinical findings. Continuing with online resources, we also browsed and found multiple sites which had audios of cardiac murmurs, respiratory sounds, etc. There were also multiple videos of physical signs which were available online. So this is one site which we had actually used and found to be very useful. So this had all the hard sounds. So we could actually download this even in our phone. We send this on WhatsApp to the students based on the case that we were discussing that day. And we taught them based on that, like if this is a murmur that is heard at the end of your history, what could the diagnosis be? So this was something which kept them in tune with actual examination findings. So, so that was how we tried to teach them positive clinical findings. Next, coming to the background clinical knowledge. So this was again something which was done in a unit. So this was a one-note. So the students were again, it was clinical group of 20. So they divided into small groups, and each group was given, so this was on, the exercise was on cranial nerves. They were given one important cranial nerve that they needed to know. And the group of 5 further was subdivided to come up with just the important details that are required for the practical examination. So the first group was supposed to do on cranial nerve. So one person did anatomy, the other person did the pathway, the other person did how to examine for the cranial nerve clinical findings. So this was all compiled together, which was presented in the clinics, and this was subsequently uploaded on Teams where everybody could watch this. So this again helped them to boost their practical knowledge about the topic. So again, interaction was something which we had to keep working on at different stages to make sure that it was not a passive learning and the students were in tune with what we were trying to teach them. So again, we had quizzes, polls, we had such group discussions. We also had these breakout sessions, that is, the clinical group is actually a group of 20. And then we divided them into smaller groups so that they could interact much more freely with the faculty. and the faculty could also clear their doubts and all which they had over the posting. So that was an intermittent session based on the number of faculty who were available at that point of time. So what were the students' feedback for these examination clinics per se? The online links for videos and audios were extremely useful. We watched them multiple times. The videos and pictures taken of our patients were also very useful. Maybe we can have more of that. Practicing on each other and making the examination videos helped. It was done mainly for central nervous system. Maybe we can have for all the systems. So this was a feedback that the students give at the end of the online teaching for clinics. So coming to assessment, we had online end of posting for the students. So we mainly do all our end of postings on forms, which was the easiest way. So this would, we could print, give the MCQs, and the output would be given with the grading for each of them. There are also other options such as assignments and grading on Teams, which we have not actually explored much because we're quite comfortable doing the MCQs on the Google Forms. So that is the summary of how we went about teaching lectures and clinics for the students over a course of 1 month. So then the pandemic continued, and by the end of March, once it started settling down a little bit, just before the exams, we had a very short crash course. So the students were allowed to come to the ward at that point of time. And we had a in-person crash course. So there it was only 2 weeks. However, there was only 5 students in each unit, which meant that they could work up at least, like they had to work up daily and present at least 5 to 6 times before they went for their actual exam. So when they came back for the crash course, what were the thoughts that ran through their mind once they started examining real patients? It felt very distant coming back to patients. We were very unsure about picking up clinical findings, difficult to examine within time. Will we be able to catch up what we missed? The crash course and real patient pseudos really helped boost our confidence. So we had a mock exam, which was also with the patient's exam. But finally, the final exam was an online, was a paper case only. So having the crash course and having a mock exam, though we knew that the online exam, the final exam would be online, that really helped boost their confidence even when they came for internship. What did the faculty have to say about the students when they came back? They were more enthusiastic than ever. Their clinical examination skills needed guidance, but they picked up fast. Their practical-based knowledge seemed good, but needed help with examination, especially the ones who were casual during their previous clinical postings. So at the end of this whole exercise, what does this tell us? Sir William Osler said, to study the phenomenon of disease without books is to sail an uncharted sea, while to study books without patients is not to go to sea at all. So there is no real alternative to bedside hands-on clinical teaching. So the core of the essence of medical education is a collaborative experience between the teacher, the student, and the patient. And this interpersonal skill is highly required for effective teaching. Unfortunately, with the pandemic, this was a major challenge and limitation that we had. Some of the questions that our faculty had was, do we really need to keep the medical students away? Shouldn't they experience what it means to deal with a medical emergency? In a matter of few months, they were interns, they became interns, and they were neck deep in the COVID ward. So what was the point in actually keeping them away like that? So this, in unison, all the interns felt this. We were quite scared of COVID initially, but not now that we started working in wards, we are not anymore. Maybe some bedside clinics with adequate PPE during the pandemic would have helped. Again, this had its concerns, it had its limitations, including shortage of PPE during the heights of the pandemic, decline of the non-COVID patients during the pandemic. The faculty and PGs were immersed in COVID care and they had very little time to actually give to clinical teaching. And also the legal aspects that the government had laws not to have students in the wards. So, what were the lessons that we learned towards the end of this whole exercise? We realized that we learned some lessons in terms of extrapolating what we learned for UG teaching. We realized that some of the things that we learned during the online teaching can be used for UG teaching in person also to make it more effective. So we realize that there are plenty of online resources that we had not tapped into before, which would really help students improve their clinical skills. It's important to have group activities which really improved their participation, interaction, and hence helped in better learning. It's also important to prioritize bedside learning and give personalized attention to the students while they're with us. How do we prepare for the third wave? In case there is one, try to have more interactive sessions for lectures and clinics with polls, quizzes, group discussions. Try to keep the scenarios as close to real life scenarios as possible with surrogate patients, clinical vignettes, etc. And it would be good to have a short crash course at least just for the final years, at least just before they actually start internship. So that's all that I have to say. So to conclude, it's important to navigate new educational systems to provide quality education to the next generation. Most important is virtual learning is actually just a supplementary process, and that can never be a replacement for in-person teaching. So thank you. I'd like to acknowledge Dr. Anand Zakaria, who's the head of Medicine Unit 1 and the UG in charge for our department, and my mentor and guide. Dr. Tina George, who's the UG coordinator along with me in our department, and Dr. Audrin Lennon, who was actually the brain behind all the tech stuff that we did during the pandemic for the students. Thank you.